Good morning, I am Professor Loïc Guillevin from Paris University and the chairman of the French Vasculitis Study Group, which is a group of interest which has organized over the past 40 years many prospective trials in the treatment of vasculitis. The topic of the day is ANCA-associated vasculitis, and this course has been organized by the Catholic University of Argentina, and the organizers are Alberto Allievi, Alberto Orden, Sebastian Munoz, and Alex Kostianowski. I thank you very much for inviting me to participate in this course. And at the end of the talk, it will be a pleasure for me to answer your questions. I have no conflict of interest, but I must underline that rituximab has been provided free by Roche Pharmaceutical for the main recent trials. But these trials are academic and sponsored by the French Ministry of Health and the Paris Hospital and University of Paris. I will start now with the classification of vasculitis. And I would like to show you what is a vasculitis. The histology shows the fibrinoid necrosis, which is rose in the slides, on this slide. You can see this fibrinoid necrosis of the media of the artery, and also the thrombosis, which is a consequence of the endothelium aggression. And surrounding this, you have some inflammation. This inflammation is perivascular in most vasculitis. Sometimes it is absent or nearly absent, like in polyarteritis. Sometimes it is a very, very large inflammation with granuloma, like in GPA, where it is possible to observe this inflammation and granuloma far from the vessels. This classification has been organized by this group of persons. And the leader was Charles Genet, and you can see him on the right, first row. And this group worked to establish definitions, nomenclature of vasculitis, integrating the clinic, but also histology, immunology, and outcomes of patients. And it is a fantastic tool to treat patients because before treating patients, you have to understand what are exactly the disease you aim to treat. And as I told you, it integrated the histology, but also immunology with the presence of ANCA. ANCA has been discovered some decades ago and mostly divided in two groups. When the fluorescence is cytoplasmic, diffuse, it is C-ANCA, and the antigen is usually proteinase 3. On the other hand, when the P-ANCA are present, it is usually in vasculitis associated with the presence of anti-MPO antibodies. The classification is also very simple, dividing the vessels in large vessels, medium vessels, and small vessels. The large vessel, it is the aorta and the branches of the aorta. The medium-sized vessels are the arteries which are in the viscera just before, and the branches, the division branches of these arteries, like renal artery, for instance, or hepatic artery, or mesenteric artery. And the small vessels are all these distal arterioles, capillaries, venules. And based on that, you have here you see the Chapelin nomenclature as it has been established in 2012, with the three categories of vessels: large vessel vasculitis, medium-sized vessel vasculitis, and small-sized vessel vasculitis. The large vessel vasculitis comprise Takayasu's and giant cell arteritis, and the medium-sized PAN and Kawasaki. It is really important to make the difference between the three categories because the impact on treatment is major. For instance, when you treat a polyarteritis nodosa patient, you use steroids and or cyclophosphamide, and in case of HBV infection, you treat also with antiviral treatment. On the contrary, in Kawasaki disease, treatment is based on immunoglobulins. The large vessel vasculitis are treated with corticosteroids, methotrexate, anti-TNF in case of Takayasu's arteritis resistant to other treatments, and now anti-IL-6 has been introduced as a treatment of GCA. Regarding small vessel vasculitis, it is more complicated because there is some subgroups of vasculitis, one associated with ANCA, and we will discuss this topic later on. The other on immune complexes, like anti-GBM disease, good pasteur in the past, cryo, IgA vasculitis, and anti-C1q vasculitis. And for these diseases, some do not deserve treatment, like IgA vasculitis in children. Some, on the contrary, need a very intensive treatment with steroids, cyclophosphamide, and plasma exchange, like anti-GBM disease. In case of hepatitis C infection, cryoglobulinemia, vasculitis, respond to rituximab, specific treatment against the virus of hepatitis C, and plasma exchanges. But be aware also that the small vessel vasculitis, the medium-sized vessels and the large vessel are considered to be primary vasculitis. But there is a lot of secondary vasculitis occurring, for instance, in autoimmune diseases or in malignancies that deserve also to have specific treatment. And that's the reason which makes that classification, nomenclature, is really essential before discussing disease after disease and treatment of these specific diseases. Granulomatous with polyangiitis, formerly called venous granulomatosis, has been described during the 30s. And this disease is certainly the star of ANCA-associated vasculitis. But we do not know the origin of the vasculitis. We know that there is probably some causes, genetics, maybe occupational, maybe pollution, but it has never been clearly demonstrated. Regarding pollution, I would like to give you the example of what happens after the Kobe earthquake. And after this earthquake, there was an increase in the number of rapid crescentic glomerulonephritis, mainly MPA, more than GPA, and it is maybe something which advocates for the responsibility of some pollution in the occurrence of the disease. However, when you look at the countries where the disease is prevalent, they are more in Northern Europe, a place without any pollution on most of the territory. Genetics is also certainly implicated in the occurrence of this disease. For occupational, we never proved anything about fumes, work, and so on. Regarding tobacco, we observed that most patients with ANCA-associated vasculitis do not smoke. I would like to come back on the genetics in ANCA-associated vasculitis. A GWAS has been organized and published in 2012. It was based on a British cohort and organized by the Cambridge Group, and the replication cohort was from all Europe. And when you look at the results, you will observe first that there is a difference between the description of the disease based on clinical symptoms and histology and the categories based on the presence of anti-PR3 or anti-MPO. There is a slight difference, but there is a difference. And it means that the clinical symptoms probably do not reflect exactly what is the ANCA-associated vasculitis and their subcategorization. During this work, it has been shown that in GPA, some genes were implicated, HLA also, HLA-DP for instance, SERPINA1 and PRTN3 in GPA. If you look at the group of patients with microscopic polyangiitis and anti-myeloperoxidase antibodies, HLA-DQ is more present, more prevalent, which is not the case in GPA. And another GVAS has been organized for eGPA. In this disease, we confirm with genetics that it is not an homogeneous disease. There is two categories of clinical symptoms and antibody subsets. The anti-MPO subgroup is mainly associated with HLA-DQ locus. And in the group of patients without anti-MPO, we do not find any HLA, but variants at the GPA33 and IL-5 or IRF1, which can have a major impact on treatment choice. I will leave now this genetic consideration, going to more clinical description. The three major symptoms in GPA affect ENT, lungs, and kidney. But all the constitutional symptoms can also be present: fatigue, fever, weight loss, purpura, neuropathy, and so on. The ENT manifestations are, after a few months of evolution, as observed here with a saddle nose. When you make a CT scan, you will observe the sinusitis, but sometimes also some destruction, and we know that the patients present also with otitis, rhinitis, with crust and blood, and sometimes more severe complications of the disease. The lung. The lung, you can see here a nodule with cavities. The CT scan, of course, should be done. Not only the X-ray, which is not sufficient to detect the nodules and to make a diagnosis of extension of the disease. On this CT scan, you see the typical manifestation. Cavitation in the nodule, and this cavitation is present in approximately half of the patients. And progressively, all the nodules will have an evolution with cavities, then after healing and disappearance of the nodules. The wall is thick. And when you see what is observed around the nodule, it is some ground glass images which are in favor of a local hemorrhage. Sometimes the nodules can be very large with a big granuloma inside the nodules mimicking aspergillosis, for instance. Pneumonia can be present, associated with lung nodules, and sometimes very severe manifestations with alveolar hemorrhage. And in this case, of course, the patient had a very, very severe hemorrhage, and it needs a very aggressive treatment in intensive care unit. This alveolar hemorrhage can be more discrete in some patients, as shown here in this CT scan. After the ENT and after the lungs, you can observe a renal involvement. This renal involvement should be searched systematically with only a dipstick to look at hematuria, proteinuria, and you will see sometimes, but quite late in the evolution, a renal insufficiency. It means that when you make the diagnosis of GPA, if a renal insufficiency is present, it is probably the aggression of the kidney a few weeks and sometimes a few months before you make the diagnosis. When you make a biopsy, you will find in every case an extracapillary glomerulonephritis. I will now explain you what happens in the kidney. If you look at the upper image, you will see this red spot, which is a bleeding in a normal glomerulus. The consequence of this bleeding is that in the urinary chamber, there is an accumulation of cells. All the blood cells are present here. And of course, these blood cells go in the urine. It's why the detection by the dipstick is really very important to make. If you do not do anything, you will have some ischemia of the glomerulus. You see here the crescent, but a very large urine chamber, and at the end there is the destruction. This destruction is present here with fibrinoid capsular rupture and the proliferation with a very, very high crescent. And of course, at this stage, the lesions are irreversible. In addition to the other clinical manifestations of GPA, the eyes can be affected. It can be like shown here, a scleritis, very painful manifestation, which can go sometimes to ulcers, and also it is possible to observe, like shown on this slide, orbital tumor, and this exophthalmia is shown also on the CT scan. You can see how it is severe with a granuloma which pushes the eye out of the orbit. Vascular manifestations on the eye are also present with ischemic process, and as I shown you previously, the scleritis can be complicated by ulcers. What you see here is a very thin superficial cornea, and behind you can see in fact what is inside the eye. Do not forget that in vasculitis, digital ulcers can be observed, and purpura is also sometimes present. Very rarely, it is also possible to observe, as shown here, a pyoderma gangrenosum. It is not a clinical manifestation of GPA, but an association which is not fortuitous. And when you treat the patient for GPA, you will observe the disappearance of this very active and very severe pyoderma gangrenosum. Patients complain sometimes of headaches, and when they have headache, you have to look at pachymeningitis, as shown on this slide. But the granuloma present in the pachymeningeal can be also present here on the spine, and some vascular manifestations have been also observed previously in the brain. Now, histology is not so frequently obtained than in the past, because we have the clinical description, we have the ANCA, and to make a biopsy is not useful in some patients. But anyhow, here it is a lung biopsy, and you can see the inflammation, the granuloma, and the giant cells. This giant cell is more clearly shown here, and it is a characteristic of this disease. It is sometimes very difficult to find the vessel itself with fibrinoid necrosis because there is a lot of inflammation, granuloma, and giant cell. I would like to move now to the eosinophilic granulomatosis with polyangiitis, which is a rare vasculitis. When we organized a prevalence study of different necrotizing vasculitides in the county of Seine-Saint-Denis, where I worked previously, we observed that the prevalence of EGPA, CSS on this slide, was 11 per million inhabitants, which has been confirmed by other studies. The clinical manifestations of EGPA are those of all the necrotizing vasculitis, but with some specificities. In a retrospective study based on 383 patients, we showed that the median age was 50 years old. It is younger than GPA and MPA, based probably on the fact that patients who develop EGPA are asthmatic for most of them long time before the occurrence of the vasculitis. There is no difference in sex ratio, and ANCA are present in less than 30% of the patients. The clinical manifestations are asthma, which is nearly compulsory. It is not 100% because some patients will develop asthma after the first clinical manifestations of EGPA. Peripheral neuropathy is usual, as ENT involvement. But ENT involvement is not exactly the same that has been described in GPA. It is polyposis in the nose and in the sinus, and maxillary sinusitis. Skin lesions are purpura, and lung infiltrates are one of the most prevalent clinical manifestations of the disease. Some other manifestations are rare, but their severity leads to death in some of them. Cardiac involvement, for instance, as GI involvement or renal involvement. Less than 20 or 25% for each of them. Regarding renal involvement, it is like in GPA, crescentic glomerulonephritis, exactly the same. For cardiac involvement, it's a bit different according to the subgroup with ANCA or without ANCA. It is more frequent when ANCA are absent. And than that, when you look at the prognosis and at the outcomes of patients, you see that the 5-factor score shows that 76% of patients have in fact quite a good prognosis. The severe manifestations are present in 25% of the patients. The ANCA positivity clearly shows there is two subgroups in the disease, one with ANCA, 30%, with less cardiac involvement, more peripheral neuropathy, more kidney involvement, and the big subgroup is patients without ANCA, where cardiac involvement is more prevalent. The death is low, 11%, and relapses 25%. I just would like to tell you that it is not so easy to make the diagnosis of relapse of EGPA, because patients relapse with asthma, usually, eosinophilia, but the extra pulmonary manifestations are not present. And it is very difficult to make the difference between an asthma flare with eosinophilia and an EGPA flare, including asthma and eosinophilia. What about the relapse-free survival? You can see that it is different according to the ANCA, and the overall survival is, of course, much better when patients are ANCA positive, and it is linked clearly to the presence or the absence of cardiac involvement. The major risk factor for death is cardiomyopathy. The others risk for death are cancer, but it is not different than expected in the general population. The death due to cardiac involvement can be immediate, but in most patients it occurs later, months or years after the first clinical manifestations. I would like to focus now on the treatment of ANCA-associated vasculitis. But first of all, I would like to tell you a few words about the treatment which was proposed several decades ago. And you have to remind first that when the patients with vasculitis are not treated, they die. And when you look at this slide, you can see that the population of patients without treatment, the survival was only 13% after 90 months. And the treatment which has been shown to be effective, the first one, was corticosteroids. But very quickly, many patients were refractory to corticosteroids only, and they have presented many side effects. And for this reason, only in the 70s and 80s, the treatment which was proven to be effective was cyclophosphamide combined with corticosteroids. This slide focuses on the population of polyarteritis nodosa, but it was before the description of ANCA, and many patients in this series of patients probably present another disease like microscopic polyangiitis. And now we have the same drugs, corticosteroids, immunosuppressant, plus of course rituximab, and the treatment has changed. It has changed because we have understood how to manage the treatment with the drugs we have, and we have also reduced the dose of each treatment, and you will see what is possible to obtain now in terms of treatment of ANCA-associated vasculitis. I would like to address a few questions. First, does classification that I have described before play a role in the treatment decision? Second point, induction treatment, immunosuppressants or biologic, and what else? Third question, do patients need a maintenance treatment? And fourth question, how long and how to treat in the long term? And of course, I will detail also some practical measures to help the patients during the treatment of vasculitis. Regarding the first question, classification, I have clearly demonstrated before that this classification is essential to make the difference between one vasculitis and another vasculitis, and you will see that the treatment is different. The second question is about the induction, immunosuppressants or biologic. And you have a choice to make. But you have also the choice between immunosuppressants and steroids only. I would like to present you now the 5-factor score. It is a last version. We have published 2 different 5-factor scores. This one is adapted to polyarteritis, eGPA, and GPA. You can see that 4 items are associated with a poor prognosis: the age, renal insufficiency, gastrointestinal involvement, and cardiac involvement. And we observed also that patients who present an ENT involvement, and it is true for GPA and eGPA only, have a better outcome than other patients. This score, it is a score to predict mortality. But we try to adapt the treatment to the score because we think that when it is a benign form of vasculitis, it is better to treat with only corticosteroids and not to use an immunosuppressant. Or if an immunosuppressant is chosen, we try to minimize the power of the immunosuppressant and to choose what I call a light one. The treatment of vasculitis comprises 2 periods. The first one, it is induction and remission treatment. To obtain a remission, it is the objective of the treatment, and of course to obtain remission without or with few sequelae. The second part is a maintenance treatment. The aim of this treatment is to prevent relapses. The conventional treatment for vasculitis can be summarized as shown on this slide. A combination of cyclophosphamide and steroids in systemic diseases, methotrexate for non-renal GPA, corticosteroids alone in some patients without poor prognosis factors, it means FFS 0, and these diseases are eGPA and MPA and not GPA. And azathioprine or methotrexate for maintenance treatment. In the category of patients without poor prognosis factors, 2 diseases only, MPA and eGPA, corticosteroids alone. And we have shown recently that to combine in this group of patients steroids and azathioprine is not useful. We designed a prospective trial comparing 2 groups. One group is treated with corticosteroids and azathioprine, and the second group with corticosteroid and the placebo of azathioprine. And we focus the population of eGPA, PAN, and MPA without poor prognosis factors, which means FFS 0. The design of the trial is shown on this slide. The 2 groups, and corticosteroids has been scheduled to be tapered progressively until a minimum dose or stopping corticosteroids. And the decrease, the tapering, was perfect and exactly the same dose in both groups. At the end, it is not zero corticosteroids for one reason, which is the population of patients with EGPA. And we know that in EGPA, most people are kept under low-dose corticosteroids, around 7.5 milligrams per day, only to prevent the occurrence of asthma and to control asthma. But I will come back on the result of this study named SUSPEND-2. You can see that the remission without relapse and the remission rate and the number of deaths is not significantly different in both groups. And it means that azathioprine is not useful to prevent relapses and to better control the disease or to taper corticosteroids. And for this reason, we think really that in some systemic vasculitis, corticosteroids alone is enough and you do not need to prescribe an immunosuppressant. Now, what to do for the other patients? The other patients are those with EGPA and MPA with poor prognosis factors, and in all patients with GPA. The conventional treatment is to attribute cyclophosphamide to the patients. We treat usually with pulse cyclophosphamide, but in the United States they like still now to prescribe oral treatment at 2 to 3 milligrams per kilo per day, which is as effective and maybe better in terms of effectiveness, but unfortunately with more side effects and the probability of developing side effects in the long term higher than with pulse cyclophosphamide. For pulse cyclophosphamide, we give 0.6 to 0.7 gram per square meter or 15 milligram per kilo, which is exactly the same, at day 0, after 2 weeks and 1 month. And after, we give the treatment every 3 weeks until remission. And usually we stop after 6 pulses. In patients who are old or who have a renal insufficiency, we give only 0.5 grams square meter. And now, in some patients, we propose to treat with 500 milligram fixed dose at each pulses. And the results are good. There is another option to treat the patients effectively, which is plasma exchanges. Plasma exchanges, we know for decades that this treatment does not improve survival. And we demonstrate this with a very, very old study published in 1995, where we randomized in PN and ANCA-associated vasculitis patients with corticosteroids and cyclophosphamide in one group, and corticosteroid cyclophosphamide and plasma exchange in the second group. And you see that the survival rate, first is good, and second is comparable. And in another study, which was MEPEX, the results in terms of survival is exactly comparable to our previous study. MEPEX is a very interesting study because for induction, all patients received steroids, all patients received oral cyclophosphamide, and in one group, they received at time of diagnosis pulses of methylprednisolone, which were compared in the second group after randomization to 7 plasma exchanges given within 2 weeks. And the population was of renal insufficiency in ANCA-associated vasculitis. Very severe patients, more than 500 micromoles. 150 patients have been included. The results were as shown here. No advantage to prescribe plasma exchanges to improve survival, but clearly better results in terms of recovery. Plasma exchanges are effective to delay the occurrence of renal insufficiency or to improve quickly the renal outcome with lower creatininemia. You probably know that there is a second trial called PEXIVAS, which has not been yet published, but we know the results which have been presented in several congresses. In this PEXIVAS study, there is no difference in survival, no difference also in renal insufficiency. But I would like to underline that the protocol was not exactly the same as the MEPEX study. In detail, all patients included in PEXIVAS, and it was more than 700 patients, have been treated with corticosteroids and pulse methylprednisolone, immunosuppressant, and they have been randomized to receive or not plasma exchanges. And it makes a difference with MEPEX, because MEPEX was pulse methylprednisolone versus plasma exchange. And in the PEXIVAS study is methylprednisolone for everybody, and after that, plasma exchanges or not plasma exchanges. And this absence of difference, in my view, shows something very important. It is that to treat a patient with vasculitis, pulse methylprednisolone are very effective. And very effective when given early. You should not prescribe pulse methylprednisolone to every patient, but when the patients have a severe disease, it is a good option. And plasma exchange, for me, is now a second-line treatment. It means that when creatininemia or alveolar hemorrhage do not improve very quickly with pulse methylprednisolone, oral corticosteroids, and immunosuppressant, I like to prescribe plasma exchanges in addition to this treatment, and the results are quite good. We obtain usually a very good response. I know also that this response is not for life. And when you have destroyed your kidney, you have destroyed your kidney, and renal insufficiency could occur later. But it is really a good option. Now I would like to go to the new drug. The new drug is rituximab. Rituximab has been proposed in 2 randomized controlled trials published now 10 years ago. And I will only comment the results of the American trial, which I think has a better methodology. In the other trial, rituximab was also given versus cyclophosphamide, but it was a very few number of patients, only 33. And for the first pulse, the patient could receive rituximab plus cyclophosphamide, which is sometimes difficult to analyze. The risk study is more simple. All patients receive 1 to 3 pulses methylprednisolone. In one group, they receive oral cyclophosphamide for 3 to 6 months, combined with corticosteroids. And after, they receive a conventional treatment, which is azathioprine. And treatment is stopped after 1 year to 1.5 years. In the other group, they receive 4 infusions of rituximab, which means 3 weeks of treatment, rituximab 375 milligram per infusion, for 4 infusions delayed by 1 week interval, and corticosteroids. Cyclophosphamide is given in placebo, as a placebo, and after they have placebo of azathioprine. The first analysis of this trial has been made after 6 months, and the results in both groups are comparable. The primary endpoint was to obtain a BVAS at 0, BVAS in an activity score in vasculitis, and they tried to stop corticosteroids after 6 months. This endpoint was obtained in 64% of patients in the rituximab group and 53% in the other group. The difference is not significantly different, and the result is that rituximab is non-inferior to cyclophosphamide. In these patients, the adverse events were comparable in both groups, and the events leading to discontinuing the treatment were also the same in both groups. Another question is, do patients need a maintenance treatment? I would like to come back first on the Sikazarem study. In this study, to obtain the remission, we compared with the European Vasculitis Study Group 3 to 6 months oral cyclophosphamide associated with corticosteroids, followed by azathioprine, to a long treatment with cyclophosphamide 12 months associated with corticosteroids. And what is clearly observed in this study is that the results in terms of remission, induction of remission, were the same, were comparable. And for this reason, since the publication, patients receive only 3 to 6 months cyclophosphamide associated with corticosteroids, and when the remission is obtained, they are switched to azathioprine for maintenance. Other drugs have been also evaluated to keep patients in remission. In the vegan study, we compared azathioprine to methotrexate after obtaining the remission with pulse cyclophosphamide. And what you can see on this slide is that the results are comparable in both groups, no significant difference. And to maintain your patient in remission, you can choose the drug you like. But what is obvious is that the relapse rate is very high, and at 36 months, approximately half of the patients experience at least one relapse. Other drugs have been also evaluated to maintain the remission. I will not comment on mycophenolate mofetil, but this drug has been shown to be less effective than azathioprine to maintain the remission, and also less effective to induce the remission. And for this reason, we decided to evaluate a new drug for maintenance, which is rituximab. Rituximab has been shown to be effective to obtain the remission, but what about keeping patients in remission? I come back on the results of the RIF study. Here, the results are presented at 18 months and not 6 months. And you can see that in both groups, the probability of remission and complete remission is the same. Not different if patients had a maintenance treatment with azathioprine or a placebo after infusions of rituximab to induce a remission. When the patients have been divided between anti-MPO and anti-PR3, the results showed that patients with anti-PR3 relapse much more than patients with anti-MPO at entry in the study, but the results are also comparable in the anti-MPO group or anti-PR3 group, considering cyclophosphamide followed by azathioprine or rituximab followed by placebo. But what was clear for us is that the relapse rate at 18 months is very high. And for this reason, we designed a new. The main recent study aimed to evaluate the best treatment for maintenance in ANCA-associated vasculitis. It has been published in 2014. The design of the after remission has been obtained, in one group, patients received azathioprine, 2 mg per kilo per day, for 22 months, and evaluation was made at 28 months. In the other group, patients received one infusion of 500 mg rituximab every 6 months. Results are shown here. When patients received azathioprine, 17 major relapses were observed, 28%, and in the other group, only 5%. Rituximab was clearly more effective to maintain the remission than azathioprine. The deaths during follow-up were not different between groups. And on this slide, you can see the event-free survival. After this clear demonstration, the other question to address was how long and how to treat in the long term. For this reason, the French group designed also new trials. One of them was a MENRITZEN-2 study. The objective of this study was to determine whether treatment adapted to ANCA status and CD19 is as effective as a fixed administration schedule. The secondary objectives were safety, and this trial was very successful, and we included 162 patients. The design is shown here. In one arm, patients received the MENRITZEN-1 schedule, one infusion rituximab every 6 months, and in the other group, based on the results of the ANCA titer and or CD19 presence measured every 3 months, patients received one infusion of 500 mg rituximab. It means that if CD19 remained at 0, or if ANCA titer remained negative or the same that at the previous measurement, patients did not receive rituximab. The results are shown on this slide. First, the treatment is safe, the same in both groups. It is effective in both groups. And what is very clear is that when you have a treatment on demand, patients are treated with less rituximab than in the other group. 3 versus 5 pulses and 1 gram 0.5 versus 2.5 grams for the whole treatment. Of course, there is slightly more relapses in the on-demand arm, but it was not significant, and we did not demonstrate clearly the predictive value of the ANCA titer and or CD19. What is predictive of the relapse is the presence of ANCA, not the titer. We decided also to evaluate the long-term follow-up of the MENRITZEN-1 study. What you can see on this slide, which is a MENRITZEN-1 study at 60 months, is that there is clearly a difference between groups of patients receiving rituximab and in the other arm treated with azathioprine. But you can see also that even in the group of patients treated with rituximab, some relapses occurred. The survival remained excellent, For one reason, the treatment is safe. When patient relapse, you can treat again, and the response to the treatment is really very good, and the tolerance is acceptable. If you look at the severe adverse event-free survival, no difference between both groups. And now, I would like to concentrate on the arm of patients receiving rituximab. In this group of patients, we stratified retrospectively the patients according to the presence or the absence of ANCA, and we have identified different subgroups. One is a low relapse rate. In this case, you will find patients who had a GPA or MPA without ANCA, and those who were anti-MPO positive. On the contrary, in green on the slide, patients who remain positive for anti-PR3. And you have an intermediate group, which is made of patients who had anti-PR3 at onset and the anti-PR3 disappeared or remained at low rate. Now, I will go further on the duration of treatment. The duration of treatment is not clearly solved. The tradition is to treat for 18 months, 2 years. But when you look at this UVA study called REMAIN, evaluating immunosuppressant regimen, and after obtaining the remission, patients were kept on remission with azathioprine, and it was decided after 2 years of azathioprine to withdraw the treatment or to continue the treatment for 2 additional years. And what you can see is that when you prolong the treatment, the results are better. And the survival without major relapse is better with a continuous treatment than with the withdrawal treatment. When you look at the predictors of relapse, you will find the last trial of the group is a MENRITON-3 study. In this study, we re-randomized patients who had already received 18 months rituximab to receive 4 additional pulses of rituximab every 6 months, 500 milligrams, and in the other group, placebo. The follow-up is 28 months more than what has been done before. Of course, it's very difficult to me to give you some results today because we have not completely finished the analysis of this study. But what I can tell you is that when you prolong the treatment with rituximab every 6 months, there is less relapses and patients are kept in remission with a very significant difference regarding the placebo group. This difference is approximately 20%. Another major point is corticosteroid treatment. In the United States, they try to withdraw corticosteroids after 6 months. In Europe, the tradition is more to keep patients on low-dose corticosteroids for approximately 18 months. And the meta-analysis of 13 studies showed that when patients are kept on corticosteroid low dose, there is less relapses than in the other group. Of course, it is retrospective. And I don't know really if long-term corticosteroids at approximately 5 milligrams are useful. But we have to evaluate that. And in the world, there is 2 or 3 prospective trials which will answer this question with a stop of corticosteroid in one group and a prolonged treatment in the other group. We have to wait for a few years before obtaining a clear response. Now I would like to talk with you about eosinophilic granulomatosis with polyangiitis and the treatment of this disease. You know now that it is not an homogeneous disease. And because it is not an homogeneous disease with two groups of patients, one with ANCA, 30% of the patients, the others without ANCA, we could probably use different treatments. To obtain the remission of EGPA, why not to use rituximab, especially for the ANCA-positive group? What will be the place for anti-IL-5 antibodies? These monoclonal antibodies have probably a very good future in this disease as in asthma. EGPA patients have asthma, sometimes severe, and after stopping and obtaining the remission of EGPA, most patients deserve to be treated with inhaled corticosteroids or low-dose oral corticosteroids, and why not sometimes with anti-IL-5 antibodies. In a series of 383 patients who have published in the past, you can see that the mortality rate was not very high, 11%, relapse rate 25%, and most patients were kept under corticosteroid in the long term. Now we have new drugs. One of these new drugs is an anti-IL-5, mepolizumab, and now there is also new drugs which are under evaluation. Mepolizumab has been evaluated prospectively to prevent the occurrence of relapse. It has been published in 2017, the New England Journal of Medicine, and when you compare both groups, mepolizumab and placebo, it is an add-on treatment because in addition patients receive corticosteroids and sometimes immunosuppressants. You see the advantage to prescribe mepolizumab. If you look more specifically the relapse risk, it is better to be treated with mepolizumab than with a placebo. And of course, it is not so easy to treat these patients, and we do not have all the answers. For induction, for instance, we have now designed a trial, and we have nearly finished inclusions, to evaluate the indication of rituximab, to know if there is a difference between the ANCA-positive group and the other groups. For remission, why not to try also anti-IL-5 as an initial treatment and to try to stop very quickly the corticosteroids? All these questions are open, and many trials are now focusing on that point. I would like now to conclude this presentation and give you some clues for the future. We know now that the induction treatment of ANCA-associated vasculitis is codified. Rituximab, cyclophosphamide, associated with corticosteroids, are the best drugs. I did not discuss with you the indication for plasma exchanges because it is not perfectly known if this treatment is useful or not, with some contradictory results. I have focused on the maintenance treatment. First, to convince you that this treatment should be prescribed, because relapses are not the same in all vasculitis, probably based on the presence or the absence of ANCA and to the category of ANCA. And we have observed that anti-PR3 patients relapse more than anti-MPO patients. We have identified that some patients could deserve very long maintenance treatment, especially those with anti-PR3, and others could receive, maybe, but it is not clearly demonstrated, a shorter treatment, and I am thinking to the group without ANCA or with anti-MPO ANCA. Since the demonstration of efficacy of rituximab, azathioprine, methotrexate, and mycophenolate mofetil are not the third choice to maintain remission. You should treat your patient with rituximab. This drug is, of course, expensive, but we made an economic study which showed that the treatment is cost-effective because you prevent relapses, and relapses are also costly for the health system. And now, with biosimilars, it's really a big advantage to keep patients on rituximab and not to keep them on conventional treatments. EGPA now, it's a bit different. It's different because two clusters at least have been described in this disease. And induction of remission can be the conventional treatment, corticosteroids in the FFS0 group, cyclophosphamide in the other, or maybe the new biotherapies, rituximab, mepolizumab. They should be evaluated prospectively. For maintenance treatment, we have some information demonstrated that mepolizumab is more effective than other immunosuppressants to prevent the occurrence of relapses. It should be confirmed also by other studies. The treatment of vasculitis comprises of corticosteroids, and probably that it could help to keep patients in remission, but it should be confirmed by prospective studies. And regarding the optimal dose of drug to keep patients in remission, we know that it's a compromise between the effectiveness and adverse events. And even if we have now many trials helping you to make your choice, you are facing a patient. And when you face a patient, it's you and you only to choose the best treatment. I thank you for your attention.